वापस कर ट्रांजैक्शन शुरू किया मीटिंग का मतलब जितना सर्च होंगे उतना ठीक है भले या तो न्यूज़ प्रिंट्स हाँ भले से सर्च को लिखे ना वो शुरू गए ना नहीं पता था यो कुछ भी आवाज आ रही है अस्सलाम वालेकुम आवाज आ रही है हेलो अस्सलाम वालेकुम आवाज आ रही है हेलो हेलो अस्सलाम वालेकुम हेलो हेलो अस्सलाम वालेकुम
वालेकुम सलाम।
आवाज आ रही है
यस सर आ रही है।
असल में थोड़ा प्रॉब्लम हो गया था कि इसमें ना नई आईडी हमने की तो
सर आ रही है आवाज।
हाँ पहले ये हमने डिसकंटिन्यूसली किया लेक्चर के बीच में ये था कि आईडी अब दूसरी हो गई है तो ऑल स्टूडेंट कैन पार्टिसिपेट पहले सिर्फ 100 था इसलिए ये हम दोबारा शुरू करते हैं
सर शुरू से स्टार्ट करें सर।
हाँ शुरू से हम दोबारा वेट कर रहे
और
हैं
सर कोशिश करें बैकग्राउंड में बहुत साउंड्स आते हैं आईटी वाले और ये जो भी बात कर रहे हैं।
अच्छा उसको हाँ ठीक है ओके अभी है तो कोई नहीं यहाँ लेकिन पता नहीं कहाँ से आवाज आती है एनीवे These are technical problems.
सर फर्स्ट लेक्चर हमारा ऐसे ही गया और डिस्टरबेंस हो रही थी फिर पता नहीं क्या आवाज थी।
असल में उस दिन काफी लोग थे आज तो है ही नहीं आज तो सिर्फ एक ही है बस तो try to wait
आज
mute.
वाला फर्स्ट की बात है।
हाँ अच्छा आज वाला फर्स्ट है इसको मैं बोल देता हूँ ठीक है Bismillahirrahmanirrahim. Assalamu alaikum. I welcome you all final year students and I hope you are all right and you have to prevent from the COVID-19 and by avoiding by going to everywhere, stay home and wear mask if you are going anywhere with some emergency and protect yourself and your family. Now, I started my lecture, but because of the, students were participating only 100, but now we have changed the ID and so 200 or more than 200 students can simultaneously participate and listen to the lecture. Now, we are discussing the endocrine hormones and endocrine glands of the hormones. They are very important. So today we're discussing the adrenal gland. As you know that there are two adrenal glands situated over the right and left kidney on the right side, one on the left side over upper pole of the kidney. And this adrenal gland, they are under control of the pituitary and pituitary is under control of the hypothalamus. So you can see in this slide, the hypothalamus releases the CRH, cortical releasing hormone, and this acts on pituitary and this releases the ACTH, adrenocorticotropic hormone, and this acts on the adrenal glands and produces the cortisol. Now, adrenal gland has two zones, two parts. That's called the adrenal cortex and adrenal medulla. Now, adrenal cortex again has three: zona reticulus, zona fasciculata, and these different cortex zones secretes the glucocorticoids, mineralocorticoids, and androgens. Now, androgens are secreted more in males; they are important. They needed there, but in females, little amount is secreted. But if there is an increased amount of androgens, they will have to adopt androgens on the females. So, glucocorticoids are important for the maintenance of they are anti-inflammatory hormones. They are, they maintain the blood pressure, circulatory system, and they They are also important for the glucose maintenance. So they are basically emergency hormones. Glucocorticoids, that's also needed for the maintenance of the blood pressure and electrolyte balance. Androgens are for the sexual activity, sexual organ, and the secondary sexual characters. Adrenal medulla secretes two hormones, adrenaline and noradrenaline. These hormones are called emergency hormones. Normally, they control the blood pressure, prevent from the hypertension, and also they control the heart rate. But the role is mainly the emergency when the patient has stress, an infection, or any other type of stress, or patient has an accident, or patient has hypovolemia, loss of blood. So these hormones are secreted and they cause vasoconstriction and produce maintenance the blood pressure and to supply to prevent the vital organ from the ischemia. So they are called emergency hormones. So they are released from when there is stress, when there is infection, accident, or for example, or a patient has fear, fight, flight. Now, every hormone is needed definitely, but when there is an excess or under secretion of hormone, they have to be detrimental to the body and they have produce adverse effects. So nature has produced balance. If the balance is lost, then a lot of problems can happen. One important condition which is seen commonly the excessive activity of the cortisol production from the adrenal cortex. That's called Cushing syndrome. This syndrome was described Cushing due to the excessive activity of the adrenal cortex. Now, second term you will find in the literature and the books that's called Cushing disease. What's the difference between Cushing syndrome and Cushing disease? Cushing syndrome is because of the secretion of the cortisol, increased secretion from any source. It may be ectopic, it may be adrenal glands. But when there is increased secretion of the cortisol due to the ACTH secreted from the pituitary only, that is microadenoma or macroadenoma, that's called Cushing disease. Now, causes of the Cushing syndrome is the adrenal hyperplasia, secondary to pituitary ACTH production. So Cushing syndrome can be due to ACTH because of this pituitary or because of the non-pituitary sources of the ACTH, or sometimes autonomous production of the cortisol from the adrenal adenoma, maybe benign or malignant. So pituitary hypothalamic dysfunction, pituitary producing micro or macroadenomas, secondary to ACTH or CH producing non-endocrine tumors. Ectopic secretion, bronchogenic carcinoma, carcinoma thymus, pancreatic carcinoma, and bronchial adenoma. Usually, what we see in clinical practice that the lung, lung, cancer lung, that may be carcinoma or adenoma, they are really the source. It's called paraneoplastic syndrome. So it is produced from the lung cancer and periodicity kind symptoms of the Cushing. Adrenal micronodular hyperplasia. So adrenal micronodular hyperplasia, sporadic adrenal neoplasia, adenoma, carcinoma. Now in clinical practice, what we see, the common cause of the Cushing syndrome is iatrogenic. Because steroids are widely used, people in general practice, injection decadron is commonly used, polycortics is commonly used. So prednisolone, delta-cortical, metronidazole, they are commonly used for relieve the symptoms because they give quick relief, especially the patient has arthritis, patient has bronchial asthma, the people are using for years without any consultation with the doctors. Sometimes they stop, they use, again reuse, and they develop a lot of problems because steroids have a lot of side effects. And main side effects, We see there the osteoporosis, skin infection. So they have a lot of problems, and diabetes mellitus they can also develop. So these drugs, they're important drugs, life-saving drugs, especially the steroids, in injectable form and oral form. They are used in certain situations like autoimmune disorders, SLE, especially the SLE, or other autoimmune disorders or other vasculitis, and the form of the prednisolone are available in the commercial and dental portal. But they are used under the supervision of the doctor, consultant, and for 4 weeks, 6 weeks, and then tapering they stop. Now, if you use, sometimes patient may need, you have to give the low dose. So if the patient is used drugs more than 15 days, it should not be stopped abruptly. Now, second use is prolonged use of the glucose, as I told you, and the prolonged use of acetate sometimes in different conditions. This is a very common problem seen in the clinical practice. Now, almost whole body is affected. Actually, initially the symptoms are non-specific. That's why sometimes difficult to diagnose. Now, this is the typical picture of the patient who has Cushing syndrome. So, emotional disturbances, moon face, osteoporosis, cardiac hypertrophy, buffalo hump, obesity, thin wrinkled skin, you can see, strong, and amenorrhea, pura skin ulcers, poor wound healing. The sign and symptoms, they start with the non-specific. Initially, patient develops weakness, lethargy, fatigue, and decreased energy reserve. Jaldi thak jana. Maybe having vertigo, weakness. So truncal obesity, increased height, body weight, height of weight, hypertension, fatigue, weakness. There is deposition of the fat on the upper chest and neck. So this is called buffalo tars or hump. Legs become thin. This is the difference I told you between the hypothyroidism and the Cushing syndrome. In the Cushing syndrome, moon face is there, but there is weakness or legs become thin. But in hypothyroidism, the generalized obesity. And females, they usually have amenorrhea or oligomenorrhea. In males, there is decreased libido. Hirsutism, this is seen in females because of the increased androgen activity. So excessive hair growth in the areas where we cannot find hairs. Mustaches, beard. So in females, this is an important clue that patient might be suffering from Cushing syndrome. Purplish abdomen skin become thin, peppery, poor wound healing, increased skin infections, especially the fungal infections are very common. Edema, glucosuria, polyuria. Polyuria because these cortisol causes increased water clearance even without diabetes or with diabetes. Glucosuria occurs usually when patient develops diabetes because these patients usually develop insulin resistance. They are both prone. So this is reversible, but if it continues, the patient can develop diabetes mellitus. Osteoporosis. There is osteoclastic activity increase, bones become thin, and they're easily fractured. There are a lot of fractures, especially in the neck of the femur. I told you polyuria, then definitely patient develops dehydration, polydipsia, hypertrophy of the vasculitis in females, emotional liability, depression, confusion, sometimes it may lead to the brain psychosis. So just like seen in the hypothyroidism, same thing that can here occur. So when the patient who has confusion, psychosis may be considered two differential diagnoses, hypo and the Cushing syndrome. You can see here this trial, leprosis syndrome. You can see the fellow torso, protein and abdomen, but legs are thin. These are the purpura distra. Easily bruised, delayed wound healing can be seen in these patients. The typical purpura. Skin becomes peppery, just like pepper. Now, after having a patient's history, clinical examination, you will find maybe most of the times if these findings are showed in pictures, you will find bone face. The females, especially when there is excessive hairs, there should be reason to find out what could be the, why they are there. Sometimes some females have messages, or especially the beard is familiar. The family history is very important, but the patient was having nothing, and as suddenly you start having this problem, young female, you must exclude the polycystic ovarian syndrome, because over that also leads to obesity, hirsutism, and menstrual disturbances. They should be ruled out. Now, evaluating the patient with suspected Cushing syndrome. So, some investigations are specific, some are non-specific. So, we can start with the non-specific, blood CP, urine DR, blood sugar, urea, creatinine, etc. And then you go confirm the really the patient has Cushing syndrome, and then what's the cause? Both are important. So, sign symptoms, especially the osteoporosis, diabetes mellitus, diastolic hypertension, central obesity or truncal obesity, hirsutism, and amenorrhea. Some symptoms definitely will be there, suggestive of. And in clinical examination, you think the patient might be suffering from this, you must go for screening test. So what is screening test is that 1 milligram dexamethasone at midnight, 1 milligram orally should be given at midnight, and at 8 a.m. you have to measure plasma cortisol. It is more than 50 nanomole, then definitely the patient might be suffering from this Cushing syndrome, and urine-free cortisol can be measured, so that may lead to the more than 140 nanomole. So these two tests are screening tests. If they are increased, you may not suspect, you only suspect, and for confirmation, we go for the dexamethasone test. So cortisol response on second day, 0.5 milligram 6 hourly for 4 hours, and then the cortisol is measured. The normal response, normally, if you give the dexamethasone, the cortisol is suppressed. But here the cortisol does not suppress. So if the normal is suppressed, abnormal response, then what is the source? We have to see the plasma ACTH. If the high or normal ACTH, then adrenal hyperplasia secondary to ACTH producing tumor. If the low, then undetectable, or then the adrenal neoplasia. Because when there is adrenal neoplasia, it secretes, it becomes autonomous, and it suppresses the ACTH production from the pituitary. So that will help you. If there is high, it means the source is from the pituitary, and this adrenal hyperplasia is secondary. And if it is undetectable or low, it means the problem is in the adrenal glands. Now, so we have to confirm that this ACT is from pituitary or from the ectopic source. So for the pituitary imaging, pituitary selective venous sampling and cortisol response on second day of the next dexamethasone high dose suppression test 2 milligram will be done, and inferior petrosal sinus, they can be also, sample should be taken from this. If it is positive, pituitary tumor, if it is negative, means ectopic. For the ectopic, you have to go for the CT scan of the chest, CT scan of the abdomen to see the tumor, CT scan of the, both abdomen and. Now sometimes we need the PET, even the pituitary we cannot find this, or even in other malignancies, you are not able to find small tumor, or even in the adrenal glands, you have to go for the PET scan. Now, if the patient has low or undetectable SCTH adrenal neoplasia, definitely FCT, so urinary 7 ketos or DHA, so then it is raised, should be checked, and then we go for the adrenal CT scan of abdomen, especially the adrenal glands. And I told you that you can go for the PET scan for this. So if the high adrenal CT scan tumor size is 1 centimeter, then adrenal carcinoma, it is less, then it is adrenal adenoma. But definitely we cannot say that. You did say that the carcinoma is more enlarged tumor, small is the adenoma, but definitely the biopsy is needed. Now, diagnostic tests determine the type of the Cushing syndrome. The pituitary microadenoma, ectopic or SCTH or CRS production or adrenal tumor. So this slide is very important to differentiate. If the plasma SCTH level is increased much more, then it is pituitary adenoma. A small increase, then microadenoma. It is markedly increase. It is means from the periphery. And adrenal tumor may what SCTH will be decreased. So tumor dexamethasone test, pituitary usually less than 10% response, and pituitary adenoma was 95%, and ectopic less than 10, adrenal tumor less than 10. So this is how you can differentiate that this is a tumor from the pituitary, micro, and micro, or ectopic source, or adrenal tumors. The treatment reduce the pituitary acid production. Depends upon the cause. Where is the problem? Is in pituitary, or in the adrenal gland, or in the ectopic source. So, if the patient has pituitary, then definitely the tumor should be removed surgically. Treatment reduce the pituitary acid production is transdistal section of the microadenoma, or go for radiation therapy, laser therapy. There are different terms are used. And if it is inoperable, or sometimes patient not fit for surgery, you go for medical treatment. We're discussing what is medical treatment. The treatment reduce or eliminate adenocortical secretion. Now, adenocortical secretion, when I told you that this is usually tumors, maybe malignant, maybe benign, and that secretes autonomous, becomes autonomous. It is independent of the SCTH production. And so, what you have to do? So you have to go for there are two things that either you go for the tumor should be removed surgically. It's possible to reduce the eliminate the adenocortical secretion. So if there is a both involved, then go for the bilateral adenectomy. But if the one is involved only, then definitely you remove the adenoma, or sometimes it is not possible, you can remove your adrenal gland, or inoperable, then or the patient has malignancies, and you go for the check and treat that malignancy along the pancreas or thymus, whatever, it should be treated accordingly. Now, if the patient does not fit for surgery or does not want to surgery, then what should be done? So we have medical treatment, but medical treatment, as you know, that is given whole life because it will not affect the disease process. It is just to reduce the formation of the cortisol. This is a lifelong, and definitely sometimes if the malignancy, the patient usually dies, maybe 1 year, 2 years. So medical adenectomy can be, we can give the drugs metarapone, mito-10, then amanoglutaphamide, ketoconazole, cabergoline, paclitaxel, and mifepristone. Now these are act drugs on the receptors. Now different drugs are available. It depends upon the person's choice and the CD side effects, and you have to start with the drug. But patient should be told that these drugs are taken whole life. Because if the patient stops medication, definitely he will have to again develop some symptom and signs. The treatment is surgical treatment is really successful, especially when there is a benign tumor is very good. If there is a malignancy, even that the surgical treatment is very important. So it's a multidisciplinary therapeutic approach. So if a patient has malignancy, we go for surgery, and also we can take help from the oncologist. Overall, important thing is that you have to be suspicious. You have to correct diagnosis by advising correct investigation and advising correct treatment. Thank you very much.
Question answer agara question audience को लिखे दो
Question है दिखाइए ना
हाँ
गोल्ड का जो सब गड्ढे तो था
ओके
एंड